great overview of the regulatory structure in Japan and Panama and how it potentially can impact how things can run in Mexico. And also, it's always good sometimes not to be the first at things, just because you learn from other people's mistakes, and you also see the good things, and that way you can craft the best of all worlds. So I was asked to give specifically an overview of mesenchymal cell therapy. So as you heard, my day job is I am a cardiac surgeon and an interventionist. So I do catheter-based interventions, both catheter-based valves, biological-based therapies, open heart surgeries, heart transplants, kind of everything in the chest. But I actually have an integrated program where we do translational medicine, where we have our own basic science lab, translational lab, and actually clinical trials with standard therapies. And so what I'll go over is specifically mesenchymal cell therapy. But this is something I've been doing for over 15 years now. So based on not only my clinical work, but my graduate work, that basically, bottom line is, I take care of patients. So all the science you hear about in that always is driven towards patient-based care and how to optimize therapies for patients who are told they don't have any options. How to make it safe, reproducible, cost-efficient. And that's kind of our general message across everything we do. So specifically when it comes to mesenchymal cell therapy, a little bit of basic science here. So it's discovered in the early 70s, and these are specific cells that are all over your body. So to give you an idea, even though there's a lot of science here, which cell markers, which ones they don't have, they differentiate into fat, cartilage, and osteo. But let me make it even more simple. Everyone in this room has lots of mesenchymal stem cells in their body. The way you know whether your stem cells, specifically mesenchymal, work or not is if you get a paper cut, initially it starts bleeding. Then you get platelets, which stop the bleeding. Then you get neutrophils, or white blood cells, monocytes, and fibroblasts. But basically you get an inflammatory response or inflammation of healing. If your mesenchymal stem cells don't work, you get what's called hypertrophic scar or keloid formation. If your mesenchymal cells work, you get a nice little line and it goes away in a couple of weeks and you get just a little bit of scar. That's the most basic example of how mesenchymal stem cells work. They are immunomodulatory cells that exist in every organ of your body. And they have many unique properties which make them ideal for regenerative medicine and clinical therapies. So a lot of what I'm going to go over is not in animal or phase 1 or 2. Many of these are fully approved therapies around the world based on these unique properties, as opposed to many of the other stem cells that you hear about. Mesenchymal stem cells or stromal cells are very unique because they're not just about regenerative medicine, they're about immunomodulatory therapies which can affect many different organs in the body. So when you look specifically at where do these cells come from, as I said, they're all over the place, but when you look at therapeutic uses, they mostly come from the bone marrow, adipose, umbilical cord, bone, or muscle. And there have been many trials actually showing all the different sources. But the most unique thing is that umbilical cord actually has the largest per gram of stromal stem cells that you can get. And the key is these are universal, i.e. that every one of these can be taken from someone in this room and given to everyone else without an immune reaction. Now, that's not at an unlimited dose. There are fixed doses, ideal processing, and things which I'll go over. But they are potentially a universal donor, and this has been proven in many clinical trials and has led to approved therapies now in Canada and in Europe for graft versus host disease in both pediatric bone marrow transplant and in adult. So these actually do have unique immunomodulatory properties. But some of the key components is, if you think of most of the patients that we're trying to help, they have disorders such as heart failure, stroke, spinal cord disorders. These are all parts of your body that now have a hostile environment. So if you take regular stem cells that are grown in culture in these ideal environments and you put them in the patients, it's not that the therapy failed, it's the person who manufactured them failed. Because you grow them in these ideal conditions and then you put them into a very hostile environment, majority of the cells all die. And then everyone thinks, oh, the therapy failed. No, it's the person who designed the manufacturing who failed because they did not understand the biology. And that's where this integrative approach of the physicians, the clinicians, and the scientists work together. Scientists come up with great things, but most of them have no relevance to patient care because they don't actually talk to the front line of physicians who take care of these patients and see this disorder. So scar tissue and hostile environments are very important. That's why we basically can create most of these mesenchymal cells in a hypoxic environment. So very low oxygen, but also for people, I'm from Salt Lake City, Utah. So we live at a relatively high altitude. So we have to take that into consideration when we're coming up with therapies. So many places in Mexico, you have higher altitude. So if you take regular mesenchymal stem cells and apply them to that population, they're not going to work. Most of them will fail. So we actually create our mesenchymal stem cells specifically in a hypoxic environment. And what that does is it releases better growth factors, but it also gets rid of a lot of the inflammatory processes. So we get better cell survival and engraftment and functional activity. But it's taking things that are common sense. If you're going to put cells in a hostile environment, train them ahead of time. Just like you train for a marathon, why wouldn't you train your cells for that same sort of marathon? We also take into account, well, most cells, we're treating humans, right? So everyone shows science slides, no matter what meeting you go to or anyone you talk to. Every animal has been cured of any disease, whether it's heart disease, cancer, all the animals show incredible data. The problem is, we're trying to treat humans. So when we look at any type of cell-based therapy, the ideal approach is to make a cell-based therapy that has no animals. So if you're treating animals, use animal cells. We're treating humans. So all the culture media that are used to basically grow stem cells, the majority of them have fetal calf serum. So they're all made either of cow parts or pig parts. And if you look at a lot of the antibodies, they come from goat, horse, donkey, rat, pig. Sometimes it's 5 different antibodies. So you have an entire farm of animal proteins going on human cells. So when you're a patient, their immune system sees these cells, will just attack these proteins. So we actually came up with an approach in our lab and many others now where we can basically make xeno-free or animal-free media, and it makes these cells, which a lot of times grow at 24 to 30 hours of doubling, down to 15 hours. So they become very young, very small, very functional, and if they're in hypoxic areas, they're incredibly supercharged. And this is just, we're not using genetic engineering or anything, we're using common sense. And that's how we take an approach to this. We want to treat patients, so we basically made a completely xeno-free environment. So even the enzymes we use don't come from animals, so we don't use trypsin. So we make an entire cell culture that is completely animal-free and synthetic-free. But we get young, very happy cells that can be used universally for many different patients. So if we start with the most basic thing, everyone wants to cure every type of neurological disorder, but using an umbilical cord mesenchymal cell or bone marrow, you can actually come up with neural progenitors just with the right type of culture environment. But specifically, you also want to look at a spinal cord. So in spinal cord, there's many different trials of umbilical cord, bone marrow, treating both the acute but more likely the chronic, where you can actually see objective recovery of these patients. Now, if you say, can you, around the world, can you cure patients who have spinal cord injuries? That's unrealistic. What you can do for most patients based on the technology that's available, especially with mesenchymal stem cells, is you could probably improve at least 2 levels of motor function and on average 4 levels of sensory. So especially with paraplegics, things like that, improving bladder function, sensory things, those are objective things. These are done today. So these are very realistic approaches. The ones where everyone has a miracle video where you inject cells into the spinal cord and patients start walking again, it may happen, but it's not reproducible. Just because those are patients probably who have only partial cord injury with mixed scar. And mixed scar treated by mesenchymal stem cells improves incredibly. So you'll always hear of one patient who has a miracle. But we're looking at therapies that are safe, reproducible for thousands, if not millions of patients. So we have to be very realistic in our approach and scalability. So one of the very unique things about mesenchymal stem cells is because of their immunomodulatory capabilities, in Asia, they're actually used for kidney transplant to either prevent rejection with either donor mesenchymal stem cells, or to actually treat the rejection at a month out using an off-the-shelf or allogeneic bone marrow mesenchymal stem cell. And these therapies actually reduce the amount of immunosuppression that is required to have a healthy organ, because that's a natural part of your healing process. You need mesenchymal stem cells to actually attenuate or modulate the inflammation. So if you use it at the time of transplant, you could actually reduce the amount of toxic medications that usually affect the kidney and the liver when you do any type of heart transplant, kidney transplant, liver. So these are very realistic approaches. We're not magically trying to cure everyone, but we're basically trying to take the body and teach it how to heal itself again the way it used to be when it was much younger. Specifically, probably one of the biggest uses of mesenchymal stem cells is lung disorders. And it's not just emphysema or bronchopulmonary dysplasia, but it's many different things. So in the acute, so ARDS or adult respiratory distress syndrome, so patients who go into pulmonary failure from either a viral or chemical-based inflammatory response. It's massive inflammation, and many patients die from that. Giving mesenchymal stem cells through the trachea while the patients are on the ventilator actually increases survival and actually leads to better recovery and less fibrosis. That's one of the key things here is you actually minimize the fibrosis in the lung. But the question is, well, what if you already have fibrosis? So in the cases of emphysema or idiopathic pulmonary fibrosis. So what happens is we actually took the same approach. So we took those very young, supercharged umbilical cord mesenchymal cells, and we took patients who have end-stage emphysema. So patients who, by the gold criteria or the international standards, have a low FEV1, FVC. They're on bronchodilators, and they've been smoking for many years, and they are basically on oxygen. So this is basically end-stage emphysema. What we did was we said, well, how would you treat emphysema? Well, you could give the cells IV, or you could inhale them. But we said, how can we do a rational approach to this and make it very cost-effective? So we basically did 5 arms. You either gave saline, we gave them IV, inhaled, a combination of these therapies, where you did both. This was only a 15-minute delivery, and it's about 400 million cells is maximum. And that 400 million is a very unique number because that's usually the maximum number that you can give a patient without seeing an allo or donor antibody response. Once you start giving allogeneic stem cells over 400 million in a single time, you will see an immune response. So even MSCs, as immunoprivileged as they are, they're not at the point, because as soon as you get over 400 million, your body will attack it just like a organ transplant. So there is a dose response for any of these cell types. So there is no universal donor, it's universal at a specific dose. So this is a busy slide, but what was unique, as patients who are given IV or inhaled, when their baseline, when they're sick, they did show improvement at 6 months. They did show a little bit of improvement in their oxygen requirement, and they were actually able to show it at 6 months also. But what was unique is when we had both of these, so IV and inhaled, and the reason is it's understanding the biology or physiology of emphysema. It mostly affects the upper lobes of your lung. So if you give the cells IV, they mostly go to your lower lobe, and they get trapped there. Whereas drugs can circulate and go through second pass through the liver, cells usually get trapped in the lung. So the goal was, well, what if we give them inhaled? The problem with inhaled is if the cells are too big, they just get trapped in the trachea or the segmental bronchi. So when these cells, which are only about 9 to 11 microns, they can actually be aerosolized very easily at low pressure. So if you use the same type of inhaler you use for drug, all the cells get shredded. But if you actually use a low pressure system and take 15 minutes to deliver, you actually can make this a 15-minute therapy. The key is, none of these are cures. You're not going to take someone who's been smoking for 40 years and give them 1 round of cells and fix them. But you're going to treat them. You're going to improve their lung function. Probably every 6 to 12 months, you'll probably have to come to the office and get an outpatient therapy. That's okay. that's a very safe, reproducible, because all of these are treatments. None of these are cures. Having a cure for any of these diseases is unrealistic based on things that take 20, 30 years to develop. You can't cure these diseases. There's too much scar, too many other things. But can you treat them and make the patients better and do this in a safe and cost-effective way? Yes, you can. Mesenchymal stem cells can do that. One of the biggest uses of MSCs has been for arthritis. So patients with degenerative joint disease of their hips or their knees. The most common approach has been using either bone marrow or fat, where you just rapidly process it, get MSCs, and directly apply it. Now what's unique about either source of bone marrow or adipose, many people have used this as an autologous or using their patient's own tissue. This does treat many patients. But in Europe, just as in the last 3 months, adipose as an allogeneic or universal donor has finished a phase 3 trial. So it will be an approved therapy where you can take adipose mesenchymal stem cells, and as long as the patient has even a little bit of cartilage left in their knees, you could actually give this as an outpatient therapy. So this is not something that's 5 or 10 years. This is already approved therapy. So, but the key is, it's very objective. It's based on MRIs. So you have baseline MRIs, follow-up MRIs, so that way you know exactly what you're treating. The problem is if you take every patient who has degenerative joint and you give them cell-based therapy, they're not all going to get better because it's unrealistic because there's too much variety. Most patients come and see their orthopedic surgeon when they've already had years of pain, years of oral therapy, and now it's bone on bone. And then they hope for a miracle. Can you save my joint? That's unrealistic. If you still have some cartilage left, this is very treatable, very reproducible, and every year or every couple of years, you get an outpatient injection into your knee. And it will prevent joint replacement. Very simple way of doing this. The key is, but if you can actually get MSCs and then convert them already into chondrocytes, but before they become hypertrophic and make bad arthritis, the key is, can you do this? The answer is yes. You can make allogeneic cartilage, because autologous cartilage therapy is already approved in many countries, where you take a biopsy, culture the cells for 4 to 6 weeks, and put them back in. But now allogeneic has already completed phase 2 trials in many countries now. So this is not many years away. This is either approved or within the year. Many of these arthritic or osteo-based therapies are already available. The key is, again, the hypoxic culture of the cells, because these are very hostile environments. And this is basically a summary of all the different trials, of whether it's in the knee, the hip, also whether it's umbilical cord. If you look at it, phase 1, 2, 1, 2, most of these are phase 2, but there's already the ones that are approved. Phase 2 is mostly when you've actually converted the cells already into cartilage. If you're just putting in naive MSCs into the joint, that's already an approved therapy. The naive MSCs are not all going to turn into cartilage, but they'll decrease the inflammation and they will support cartilage if it's already there. If you have no cartilage there, you actually have loss in bone height also in the joint. The only way you can help that short of a replacement, that's where you get fancy and you need not only mesenchymal stem cells, chondrocytes, but you usually need hydrogels to actually replace the height that loss. So that's much more complicated tissue engineering-based therapy. But that's still in phase 1, 2. But it's if we don't do these early therapies, we're not going to learn what works, what's safe and reproducible, so we'll never get to that next generation tissue engineered approach. Now, one of the most unique uses of mesenchymal stem cells, and this has been really reproduced well in Japan and Korea, is for alcohol-related fibrosis and cirrhosis. Giving IV doses of either bone marrow mesenchymal stem cells, or in some cases placental or amniotic, has actually shown significant improvement in fibrosis and cirrhosis in alcoholic liver patients. And this is still mostly phase 2 therapies. There is no place where it's completely approved, but you can see very positive remodeling of hepatocytes and also specifically the scar tissue. And if you look at this, again, it's many different countries around the world that have been doing this. But the key is, It's everything as simple as peripheral vein. Some of them do a true intrahepatic or hepatic artery, but the majority of these are IV-based therapies. Because if you look at, if you give an IV dose of mesenchymal stem cells, majority of the cells, greater than 90%, will end up in the lung, liver, or spleen. So if those are your target organs, IV-based therapy works incredibly well. If you're trying to go to the brain, the heart, other things, that's not realistic, because so few of the cells will actually end up to those target organs. You may get the trophic factors or secreted factors working systemically, but if those cells don't go to the brain, they don't go to the heart, they don't go to the pancreas. Rare cases. But most MSC-based therapy has been, this is something we're working on for literally almost 15 years, can you basically get bone marrow mesenchymal cells in either autologous or culture, inject them to the heart, and do hearts and growth? Now the answer is, in many cases, if you find the right patient, the answer is yes, it does work. But the key is identifying the right patient population. Because if you have mixed scar or ischemia, patients will improve. If they have full thickness scar, none of these cells actually can survive in this environment. So you're going to have very unlikely, very unhappy patients, but you're going to have a lot of failed therapies. And so the key is, can you actually differentiate your mesenchymal stem cell towards a cardiac myocyte cell? So as you kind of get to the next generation of cell therapies, as with many of these things, just like cartilage, can you convince the mesenchymal stem cell to act more like a cardiac myocyte or one of the supporting cells, so it already has the knowledge it needs of the organ that it's trying to fix? And it's more likely to work than just giving it as a blank slate and hoping magically it learns on its own. So as you learn better culture techniques, which are all very simple to do, then you can actually affect the organ more reproducibly. In the U.S., the NIH funded a number of trials like this where you actually take a biopsy of the heart and you actually make progenitor cells of each patient. The problem was greater than 25% of the cells would fail in terms of manufacturing because you're taking them from very old, sick patients. But they learned enough from this phase 1 trial that when it became phase 2, they were able to get an allogeneic cell from donor hearts. So whenever we were doing heart transplants, if there were hearts available that we did not use, they were actually able to isolate the cells and get a universal donor. So now they've actually ended up with 6 donor banks of cardiac progenitor cells, which they try to match to the patient, and currently we are in phase 2 trials of actually delivering more potent mesenchymal cells directly to patients after they've had heart attacks, or even after heart surgery where they've actually biopsied the right atrium at the time of open heart surgery. 6 weeks later, if on MRI they still have poor pumping function, they infuse the patient's own cells back into the heart, hoping to see a positive remodeling event. But these are very expensive when you do it this way. So ideally, the answer is if you can get an allogeneic MSC from a cardiac source, it becomes more safe, cost-effective, but then you have a defined potency. Because that's the biggest problem with many of these cell-based therapies. Everyone in this room, I could take adipose, bone marrow, and every one of them have a different potency profile. So if I treat the same joint problem in everyone, everyone's going to have a different response. It's like taking Tylenol. I can give everyone in this room Tylenol. Some people will get better, some people will feel the same, and some people will say they have a stomach ache or feel worse. So the problem is we have to identify the actual pathophysiology that we're trying to treat and then apply the biologic to it instead of hoping that just one mesenchymal cell or one biologic is magically going to fix everything. So we said, well, let's go back to the bone marrow, and if we could take all the different bone marrows in the room and put them in a bioreactor, and so all the weak cells die, and then try to make a defined product with defined potency. So we actually tried this, and we actually now finished a small trial, and we just finished a phase 2B trial that the data will be out in February of next year. But it's in heart failure patients, and specifically just ischemic heart failure, because we found that bone marrow mesenchymal or enriched cells actually work much better in ischemic patients. Now, a similar group said, well, if we just get a very young donor, basically between 19 and 21, and get just bone marrow mesenchymal cells, they actually did a dose-based study of 25 million, 75 million, or 150 million cells. They found that if the patients got 150 million cells, At 40 months out, they had no readmission of their heart failure, no advancement of their heart failure, and no adverse events. So they did a dose-finding study, and now this has advanced to a phase 3 study, not only in the US, but in Europe right now at about 50 different sites. They're in the process of enrolling about 1,200 patients for this trial. So this is a pharma-based study. It's very large, but basically the science supported that an allogeneic-based MSC. Now the problem is, this was made with a lot of the older technology, with a lot of the animal products in that. So it's not that 150 was the best dose, 150 is the highest dose with this product before you start seeing antibodies against it, because it had many different animal components in this. So this is basically 3 generations ago therapy, because a lot of the technology is improved. But the key is, it's already in phase 3. This exact cell in Europe is already approved for graft versus host disease, and in Australia is already approved for arthritic joints. So it's not that one day it hopes to, already other uses have already been approved for this. Now again, going back to the course, in that same patient population, we're able to take a younger cell, so looking at properties such as embryonic cells. Many umbilical cord cells, if you culture the mesenchymal stem cells correctly, they are very potent. They are very young, and they have lots of capacity to go down many different pathways. So what we're able to do is say, well, can we deliver them backwards into the heart, basically retrograde through the venous system, and actually marinate the entire heart with these young cells. So we're able to do this very cost efficient and as an outpatient, so the patient's usually awake for this procedure. We did early on a very simple safety study, both in ischemic and non-ischemic patients, only 100 million cells. And what we're able to identify, even at a year out, that the patient's ejection fractions had improved, their walk times, they're also VO2 max, so basically their oxygen consumption with minimal adverse events. And we're able to show this both in ischemic and non-ischemic patients. We've done much larger trials now, but this is again taking a very simple approach of a mesenchymal stem cell and defining the patient population. So these patients had mixed scar, not full thickness scar. Full thickness scar cannot be treated with cells or gene therapy. That's where you actually need to do extracellular matrix therapy or some of the newer things which we're doing in regenerative therapies. But MSCs do help patients with mixed scar and ischemia, very reproducible. These patients do get better. But the biggest problem is, as many of these patients have heart disease, they also have type 2 diabetes, which also goes together. So not only is it a muscle receptor problem, but they also usually have limb ischemia, they also have multiple problems. So the limb ischemia component of type 2 diabetes in Europe is already an approved therapy. So you can take a bone marrow mononuclear cell or MSC, inject it in patients' legs, and basically the rate of amputation is dropped by 50%. So this is objective reimbursed therapy in Europe already available. But when you're specifically trying to treat type 2 diabetes at its primary source, using at least an umbilical cord-based mesenchymal stem cell, they've also been able to do it with bone marrow. In a small sample set, they basically looked at patients who were on oral medications who had deteriorated to require insulin. They're able to find in the small pilot studies that half the patients no longer required insulin. But the key is, this is still an immunomodulatory problem. So most of these patients required a second dose every 6 months. So that's still better than advancing diabetes and having all the end organ damages of renal failure, retinal problems, all the limb ischemia problems. So the key is, even if this is every 6 months, this is great potential for diabetes, type 2. Anyone who uses the MSCs for type 1, it only works if you give it in the first couple of months after diagnosis. Once you have full-on antibodies and you have very little islet cell activity, MSCs don't work. That's just unrealistic to expect that for type 1. Early onset, yes. But type 2 diabetes, the likeliness that it actually does have supportive benefit, very likely. So the key is, again, identifying the right patient population that may actually benefit from an MSC-based therapy. If you try to just have one cell and hope it works for everything, all the therapies are going to fail, and for the few that it actually might have worked, everyone will overlook it because everyone's already upset that it failed so many times that you're never going to use it for the few things that it should have been. But the key is, it shouldn't be that you're looking for science and then trying to find a patient. It's the opposite. You find patients with very defined disease, and then you look for the biologic which may fix it over and above standard of care. It makes standard of care much better, because if you try to replace it, you end up with a lot more complications and also unrealistic expectations. So in summary, mesenchymal stem cell therapy is clinically viable, very safe, when done in the correct way, with the right environment, the right patient population, and the right checks and balances. It is approved in many places around the world for graft versus host disease. It's also going to be approved for arthritic changes. So there's many approvals either already happened or going to happen. And this is not just autologous, this is the allogeneic, but done at the correct dose. But specifically using the key things such as hypoxia, xenophoresis, these are all things that not only that are done in my lab or the groups that I work with, but there's many groups I work with in Europe, Asia, South America, where we actually bring these cells and we teach the local labs and the local institutions how to grow them there. So each one of these countries has their own unique cord-based MSC population, which then they can mass produce. So we've done this in Panama. So in Panama, they have all of these technologies there, which they can scale up there. So it's not that they need shipments from the US. They can just grow them in their GMP labs there and use them for their own patients. But the key is it's very safe, very reproducible, and then further to clinical programs, the key is it has to have the correct regulations, which you heard from the last talk, but having the clinical registries that it leads to very safe patient outcomes, and it has to be reproducible for a number of therapies, and that way this can become a very cost-efficient, safe, reproducible therapy independent of where you are in the world. These don't need to be $100,000 therapies. They can be much more cost-effective, very safe, because these are all treatments. And the reality is we know most of these therapies that I spoke about are all things that are going to have to be redosed and monitored closely. But so if they're too expensive, we're never going to be able to treat the patients who need it the most, but we're also not going to see the benefit because we're always going to be looking for the sickest patient. The key is most of these MSC-based therapies, you're not looking at it as oncology, trying to find a stage 4 patient and hoping you can make them live 4 months longer. MSC-based therapy is long-term therapy to improve quality of life and then duration of life. So the potential is great with MSC therapy. And the key is, it's not just a stem cell, it's a stromal cell which actually helps the body heal itself. The key is, find the right patients, and there's always an MSC available that potentially can make the patient better. Thank you.